Good afternoon, everybody. Thank you for joining us today. I'm just going to give one more minute while I admit people from the waiting room, and then we're going to get started. Okay, the waiting room is clear. Okay, so thank you everybody for joining us today for the fourth part of the Housing People Who Use Drugs webinar series. Today's topic is Going It Alone program models for housing people who use drugs. And we are joined by Natanya Robinowitz from Charm City Care Connection in Baltimore, Maryland, and Kate Perch from Prevention Point Philadelphia in Philadelphia, Pennsylvania. I think with no further ado, I will just kick it over to, forgot who we decided is going first. Kate. Okay, I can get over to Kate.
Good afternoon, everybody, or good morning, good evening, assuming we've got different time zones going on here. My name is Kate Perch. I am the Director of Homeless Services at Prevention Point Philadelphia. We're supposed to be joined today by my colleague, Dale Tippet, who unfortunately was not able, and I want to just state that he is a much more eloquent speaker and summarizer of what we do and how we do it, so I hope I can do him justice. I'm going to try and give a quick overview of just kind of what Prevention Point is, what our housing program is particularly, and really then just try to go over what I think are a couple points about why I think it is so important and essential that we are operating this program as a part of a larger harm reduction services model. So for those of you who are not familiar, Prevention Point Philadelphia is a public health and social services organization primarily operating in the Kensington neighborhood of Philadelphia. Kensington is considered the epicenter of the opioid and polysubstance use epidemic in Philadelphia. It is the main area in the city where you see high rates of drug use, particularly street-based drug use amongst people who are experiencing homelessness or other forms of housing instability. Prevention Point does a wide array of services for this population. We are one of the largest, I think either the second or first largest syringe exchange services program in this country. We do HIV and Hep C linkage and testing. We do medical case management. We have a drop-in center. We do Narcan distribution. So you name it, if it's working with people who use drugs, we're probably doing it. My department specifically works on housing and advocacy for people who are living on the street. So we have two main things that we do as a part of that. We have a homeless outreach team, which is a city contract in Philadelphia. Homeless outreach is a behavioral health department managed program. We have a team that primarily focuses on Kensington, going out into encampments, into other spaces where people are living or using substances on the street and really trying to give them baseline survival supplies, food, water. We unfortunately cannot hand out anything that could be viewed as like a structure. So we're not allowed to hand out tents, which is a real disappointment. And try to link those folks into low barrier housing, medical care, other forms of services. And then our big thing is that we run a 60-bed emergency shelter program. This is a low barrier direct referral shelter for people who are living on the streets in Kensington and using primarily injection opiates, but really any form of polysubstance use. And when I say low barrier, we do not have we have security outside to help manage our relationship with the community, but we do not do bag checks or pat downs. We do not mandate that people not have paraphernalia on them when they come into the building. We say on paper, and we really do try to promote people not using in the space, but we recognize that that's a reality for a lot of our folks in order to stay well. So we try really hard not to discharge people who are using on site unless they're doing it really consistently or chaotically. We have a case management team on site that is working through our city's homeless services system to link people into coordinated entry. For our non-housing folks on the call, coordinated entry is a system most municipalities are currently required to participate in, where anybody who enters into the city's sort of homeless services housing flow gets the same assessment, and that kind of puts them in the pipeline for all of the different permanent or long-term housing resources that might be available in that municipality. So how we got here really quickly is that we started doing this as a winter initiative in 2015. The city was seeing an uptick of people living on the streets in this neighborhood, people who the pretty consistent theme amongst them was heavy polysubstance use. And we knew that we were the experts at the table when it came to serving this population and providing the unique needs and services that these folks have. And I think what is so important about what we provide and why it's so important that it is embedded within this larger harm reduction organization and this harm reduction model is that we can bring things directly to our folks on site, either through our outreach team or at our emergency shelter, that other shelters might not want to bring, might not be able to bring, and in particular might struggle to justify funding for, because these might not be needs for their whole population. So for example, we, as I mentioned, Prevention Point has a robust testing and linkage to care team at our main location. We have a schedule set up where those teams are coming into our shelter multiple times a week to do the testing. We have phlebotomy on site. Just last week, we had a situation where somebody had seroconverted. They got a blood draw for another issue, and that's how we unfortunately found out that they were positive. And we were able to get a medical provider who's seeing them for MAT on site at the shelter to have the conversation with them about getting them linked to care. And because we are a shelter that accepts everybody regardless of gender, if you have a partner, we're going to bring your partner in. Their partner was living at the shelter, so we were also able to meet with their partner on site, get them linked to testing, and start doing safety planning for them as a person who does street-based sex work. So like we were able to do all of that in the shelter with those people, with care providers that are part of our larger team. And that's just something we wouldn't be able to do to that level if we weren't part of this organization. We incentivize people in terms of, we like to offer incentives for people who are doing well and completing progress, whether that's toward their housing, their medical care. And sometimes that incentive might be, extra syringes or like extra supplies that those folks might need. That's another thing that we would not be able to do if we were not part of this larger organization. We're really able to provide these services and have these conversations directly with our folks and provide them with something that other people might not be able to. The other thing that we've been able to do that I think is really important is we were able to advocate to be what's called a direct access shelter. So in Philadelphia, as in many large cities, most emergency shelter access comes through a centralized intake. So you might be in Philadelphia, it is divided into like, there's places you go during the day, and there's places you go at night. And unfortunately, in some cases, it is still divided up by gender identity. And you go there, you get like a basic and assessment. And if there's a shelter bed available, you just end up at whatever shelter you might end up at. And these are, you don't get a choice of location. You don't get a choice of maybe you've been to this shelter in the past and had a really bad experience there. A lot of our folks obviously would report things like being turned away because they were too intoxicated and were considered a safety risk. Being searched at the door and the security guard finding that one syringe that they forgot they had at the bottom of their backpack and telling them that they had to leave because they had brought paraphernalia on site. So we were able to do, so not only did we remove those barriers at our location, but we were able to advocate that we are not part of that centralized process. So we're directly taking folks from outreach teams and other community and service organizations in the neighborhood and bringing them directly in and really being able to build our service model specifically around our folks who are using polysubstances and in particular using injection drugs. So the challenge that we face more than anything is what happens on the back end. We recognize that emergency shelter is not the ultimate solution, although I do often like to make the controversial statement that for some people, especially in a smaller program like ours, where we max out at 70 beds in the winter, that community type of living might actually be something that some people appreciate. And we have had people who actually don't want to move on into more independent housing because they like the community and the safety and like the closeness that we're able to provide and the wraparound care that we're able to provide. But we are operating, obviously, as many folks are, in a system that does not, we have kind of created a bubble in our program for how we view our folks, how we treat our folks, how we engage with our folks. And unfortunately, we're frequently being faced with barriers of moving folks on into situations where there is either implicit or explicit expectations of sobriety or perceived sobriety, where there is more and more a reliance on the private rental market. So we're reliant on landlords who might not be as willing or open to work with our folks or understand some of the specific challenges that our folks face. Also, obviously, being dependent on the private market means that we're limited in the neighborhoods and the types of housing that we can offer to our folks. So, we definitely struggle with, we've created this really great space for ourselves and for the folks that we're serving. But really moving people out on the back end can be very tricky. That being said, I think that what we have been able to do, and what in particular, once again, I think being part of a larger harm reduction services organization, we've been able to do, is we have definitely been able to push the needle and push the conversation around people who are using drugs, why that's an important conversation to have when we're talking about housing, how you can't separate, that when we're talking about behavioral health and the behavioral health needs of people in housing, substance use has to be at the forefront of that conversation. And we've definitely seen a real shift, I think, in the system around looking at how different programs are working with people who are using drugs. I think especially in our emergency shelter system, those are very large. Philadelphia shelters tend to run around 100 to anywhere from 100 to 200 plus people, which I realize for some municipalities is still pretty small. I think those systems are still struggling to change because they're just trying to serve people on a really large scale. But we've been able, I think, to push the needle in some other ways. I think my 15 minutes is almost up, but just a couple more quick examples of some things that we do that I think make us really unique and that we've been able to do specifically because we're really focusing on serving these folks and doing it from a very harm reduction perspective. We do a lot of most of our frontline staff are really there to be monitors for people's safety. So we're doing bathroom checks, we're doing bed area checks, you can be as intoxicated as you want to be in the space, but we are going to be checking you. We're constantly doing naloxone distribution, both with our staff and with our participants. I'm running out of ideas here. Sorry, guys. I'm gonna stop there. Assuming folks have a lot of questions, and I'm also really excited to hear from Natanya about what the work that they're doing. So I'll stop there. I hope you gave you guys a good overview, and I'll be happy to answer any questions folks have later. Thanks.
Thanks so much. That was a great overview. I imagine we're going to get some questions, but with that being said, we're going to turn it over to Natanya from Charm City Care Connection in Baltimore. So thank you.
Great. And thanks. I'm really like every presentation I give, I like dread it. And then when I put it together, I'm like, oh, it's really nice to reflect on the work and to be among other people who are doing the work. So I just really appreciate this opportunity to be here. And Kate, just appreciate the work that y'all are doing in Philly, because it's important for us in Baltimore to have to like look to another city and say like, well, they're doing it, because in Baltimore, everyone is like, well, that's not Baltimore, but they can't make that argument quite as well when it's Philadelphia, because we're quite similar. So I just appreciate the work y'all are doing. And I also, what you said towards the end about how hard it is to find, I feel like how isolating it is to run a harm reduction program because it's hard to refer out. That really resonates. I appreciate this opportunity. I'm feeling nostalgic. And when Billy had emailed me to ask about presenting, I realized I really wanted to talk about some emergency housing that our organization ran during COVID that we're not running anymore. And so I made a slideshow presentation, and I'm not sure I'm going to be able. So Billy, will you tell me if it's coming up as slides? I'm going to try. Okay, here I go. 2 years into the pandemic, and I still don't know how to do this. Okay, I know that doesn't look like slides. Does that?
Yes.
Okay. Okay, so I really want today to talk about, for 10 minutes, a housing program that we ran during the COVID-19 start of the pandemic for 9 months. So we opened it on March 12th, 2020, and we ended it in November of 2020. I guess I want to start by just saying I was having a lot of feelings making this presentation, and I really love this photo because this drawing, because to me, housing is really about just like feeling safe and being among people you love and being able to take a load off. And that really resonates. And when we ran this program, I think that's really the feedback that we got from people, is like that at the end of the day is what they were looking for. And it's what they got from our program. And I think, you know, for all of us who do housing or work in this field or have a house, you know, like all health kind of starts from there. You know, we can't go out into the world unless we have a place to lay our head at night, and a place that is safe and a place that feels nourishing. So I will start by saying that I've worked in harm reduction, doing a lot of street outreach and needle exchange for a long time. I had never run a housing program, and I'm definitely not a housing person. So I think I always knew how fundamental housing was, but it wasn't until we ran our program that I realized just, you know, we can't do anything if we're not sleeping at night, and if we don't have a safe place to go home to. And I just feel just a lot of gratitude towards people that are running those programs. We are Charm City Care Connection. We're a harm reduction program located in East Baltimore. We kind of started off mostly as a drop-in center. The drop-in center included, community lunches, syringe exchange, naloxone. We do street outreach in our neighborhood. And then when COVID hit and the drop-in center really couldn't operate anymore, we switched over to doing a housing program. As y'all remember, that week of March, like we just really had no idea what was coming at us. So we just knew that all of our regulars didn't have a place to stay, and that they were most at risk for A, not being able to isolate, and B, had so many comorbidities that, an oncoming virus just was so dangerous for our community. So we just kind of instantly were like, well, we're going to put people in hotels, and we're going to, I guess the phrase is build the airplane while we fly it, or whatever the phrase is, but we're going to build a foundation as we were running this program. And this is an old staff photo, but this is the staff that ran the program. Let's see. Okay, so all I want to talk about today is what we did, how we did it, what the experience was for clients, what the experience was for staff, and why we think it worked. I feel really proud of the program that we ran, and it's just kind of wild to think about the things that we did on March 12th, 2020, when we didn't know what was happening in the world. Okay. All right, so the very simple of what we did is we just put people up in a hotel in downtown Baltimore. We put all of our client assistance money that we had to fund the first 2 weeks, and then we just fundraised like hell with COVID-19 funds that came through different foundations and different government organizations. We housed, in the end, about 55 people in 35 rooms. Most people were there for the full 9 months. Mix of genders and ages. We prioritized people who weren't going to be successful in other sort of housing programs. So people who use drugs and young people. We partnered with a youth homelessness organization to make it work. And yeah, the staff was our Charm City case managers. And then we also had people run groups in the lobby for our drug user health group. And we also had our harm reduction specialist who's like mostly do our outreach and our syringe services, would go and do kind of like one-on-one motivational interviewing with folks to understand how they could, prevent overdose, the different stuff they could do to stay safe in their rooms. The home to suite. So we started in a bunch of different hotels. We slowly kept getting kicked out. And we ended up at Home 2 Suites in downtown Baltimore, which I think that process was very healthy because in the end, they liked us, we liked them, and we worked together. And so I think moving when it wasn't working was smart. Home 2 Suites is like a studio setup. So this is like a picture of the room. Every room, had this little bed with a curtain, and then had like a little sitting area with a mini kitchen. There was laundry in the building, and everyone got $10 a day for like the snack machines there. There was Wi-Fi and access to a printer, and then it was just really for space to people to put their heads down. The only rules in the program were the hotel rules. So you weren't allowed to smoke cigarettes in the room. And you had to be like respectful of each other and the staff. And that we really didn't exercise. We didn't kick anyone out on our own account. People did, we had someone who smoked cigarettes, 30 days in a row, even after the staff told them every single day they couldn't. We really couldn't control that. And so that hotel is also used for long-term patients at Johns Hopkins, like cancer patients. So they were really not tolerant of cigarette smoke. But those are the only rules. You could bring visitors, you could, bring your sister and her 6 kids, which some people did. As long as it was fine with the hotel, it was fine with us. I guess I want to say the thing about this program that I think was interesting is that we ran this program. There was the major homeless organizations in the city were also running the programs, but they had really strict rules. And so I think, as Kate was saying, we take low threshold really seriously. So, I'll just say in contrast, I told you, our rule was you can't smoke cigarettes in your room. And even then, you just couldn't do it every day. Day after day. But the rules that the city was running was there was a curfew. You couldn't do drugs, and you had to sign something saying you couldn't do drugs. You had your bag searched, they had security guards. And if you left, you got kicked out. So if you were gone for more than 24 hours, you lost your room. So we didn't have any of those rules. We really just prioritized having strong relationships with the people that work there, doing wellness checks, and just seeing what people needed. We did a weekly delivery drop for groceries, and that was about it. One of the things that was lucky was that we had a research partnership with Johns Hopkins. They actually did a qualitative study, and they interviewed all of our folks that stayed in the hotel long-term. The major findings, as you can imagine, people appreciated the sense of security, having access to food. Almost everyone who stayed at the hotel reported that they gained weight, getting rest, having a place to consistently sleep. I think having a hotel that was really clean and really nice, and having a front desk staff that was trained in hospitality was huge. And reconnecting with loved ones. I'm just gonna put these slides up. There were just some really beautiful quotes that people said about their experience of just having a safe place to go to, how it impacted their sense of security, their peace of mind, how they reconnected with loved ones from that place. Having a safe place to go. And then I think, I'll just say the experience on our staff end, I think actually it's interesting what Kate said. So Kate said that people liked living in community, and we also found people liked having their own rooms, but it was really nice for staff, to be able to show up and check on everyone at the same time and be able to do that, have those frequent long-term relationships with folks. They really, they thought that the hotel model was a really good one. At the end of the program, we moved people to scattered site apartments, and that was considerably more challenging. We also, one of the reasons I think that it worked is that we found a really good hotel, and the hotel staff was just really excellent and like really came at it from like a hospitality perspective. And really, it was, you know, I mean, this was like the thick of the pandemic, and the staff was just, of the hotel, was just really bought into the work. And really treated our clients with a lot of dignity and respect. And it just was like a mixture of, you know, us being smart and finding a good place, and also just like luck, like absolute luck to find such good people. And it ended because we ran out of money. It was costing us about $50,000. Oh wait, it was costing, it was $120 per room per night, and we had 35 rooms. So we ran out of money. The city has lots of money. They're continuing to run hotel programs. They did not want us to, they wanted us to move all of our folks over to their hotel, which we did. And I think like 2 out of 35 did not get kicked out within a week. And I think that really, it's really awful and tragic. And I wish I didn't have that data. But it really goes to show that harm reduction programs are uniquely situated to serve people who use drugs. And we respect people's inherent dignity, and we are okay with the chaos, and we base our work on relationships. And you have to be able to do that when you can't depend on curfews and rules and contracts. And so it was just a shame that I don't like to simplify things around greed, but I do think that is ultimately why the program, they didn't want to, you know, subcontract to smaller organizations. And I think the final thought is just the pandemic, as many people have said, like, is an opportunity to sort of ask ourselves, you know, what our values are and what we're okay with. And I think having people in congregate shelters is just never dignified. And the way that we house or don't house people in dire situations is just the reflection, is just not humane, and it's not okay. And I think the pandemic's brought a lot of stuff to light that, you know, is important to talk about. Ooh, I don't know how to get to my last slide. Oh, that's my last slide.
Thank you so much. That was really beautiful and also sad, but really amazing work that both of you, that both your organizations are doing and have done. At this point in the hour, we're just opening things up for questions. So if folks have questions, feel free to unmute yourself, raise your hand, throw them in the chat box. I see a raised hand right away. Howie, do you want to go ahead and ask?
Definitely. Good afternoon, everybody. It's a great opportunity for me to be able to get this information. Natanya, I wanted to ask you, I remember when the program was just starting and, you know, everything that was taking place surrounding the pandemic and how panic stricken everyone was. I'm quite sure your agency tapped into a lot of different resources to fund this. I was wondering, were you able to garner any Ryan White or Hopper funds to assist with this?
Hi, Howie. Okay, we got emergency foundation funding, and then we negotiated for the Mayor's Office of Homeless Services to pay, I think, 2 months of it. I don't know. I think a lot of their money is federal, but I don't know. We didn't get any direct like Ryan White or Hopwa, but I'm not sure what their funding source was.
Cool, thanks much.
And then we have Tatiana, also has her hand raised, their hand raised, if you would like to go ahead and ask.
Hi, my name is Tatiana Orianna. I am currently a student at Stanford Francisco State University. I'm a senior, and I'm really I'm majoring in public health. This is like kind of my passion, is working with people who are, you know, using substances and trying to get unhoused individuals into proper housing. And so I guess my question of the day is, what have been the biggest challenges for you to overcome, and how have you stayed motivated despite so much, I guess you would say, just lack of cultural humility when it comes to these policies that we have in place? So yeah, I kind of just want to hear about that and how you've been going about that.
I can give it a shot. I think, like I said in my initial kind of rambling, definitely operating, and I think, as like Natanya very eloquently gave like a perfect, like encapsulated example of how this can play out in a specific set of time, just knowing that there is a limited number of spaces and resources outside of the ones that we are creating to connect our folks to. And just, you know, I think about when, like Natanya was talking about having everyone move into a hotel and only 2 people still being there, I think of, you know, how many people we've referred into, like, that we have been in Philadelphia right now. Rapid rehousing is the name of the game in a lot of ways, and like the number of people that we have moved into a rapid rehousing unit to watch them be back on the street not even 6 months later. So it's just, it can be really disheartening and really difficult. I think a couple things that keep me motivated and that keep our team motivated is, one, knowing that we are not the only ones doing this work and trying to figure this out. I think I saw that like Andy Spears from Pathways to Housing is on here, and they are a great permanent housing provider and partner for us and for our people. And they have put in the work to develop housing first teams, specifically working with people with opioid use and polysubstance use. And so that's just like a great, like, when you know that there are other people that are like fighting the fight that you're fighting and trying to work through the chaos, as Natanya put it, that's really helpful. So it's like good to know that there are, and there's a reason that when we refer people to Pathways, we see a much higher level of success than when we're referring people to resources or organizations that don't have that harm reduction focus. So that's one thing. And I think the second thing, I know, like, I'm going to channel Dale, my coworker who couldn't be here. I'm going to channel his spirit for a minute and say that, like, he says this a lot. He's like, we know that ultimately we are on the side of right and the side of good. And that the work that we're doing is important and is righteous, is like is the word that Dale would use, I think. And if our folks aren't giving, like, the people that we serve every day are not giving up in their struggle to figure out how they can live their most authentic life in the way that they want to do it. So we can't give up in like working with them to do that. So I think for me, like for me and my team, I think that's the big thing.
All those things. And I think one thing I struggle with is I work with bureaucrats, and I don't like to vilify people. And I know that people are really trying to do good, but I do think harm reduction is on the side of the righteous. And I do think we are doing what's right, and we know it. And I think being in community, I noticed it a lot in the pandemic, when you're not around other people doing the work, then you start to be like, gosh, every single person I talk to can't believe we're not kicking people out for drug use. Like, am I going crazy? And so I think surrounding yourself with people who can say, like, no, you're not crazy, like, we're doing the right thing. And that often requires going outside your own city, or really like being proactive and reaching out, and just building a community of people doing what you're doing is really helpful. I also, like, we happen to do this qualitative evaluation of our program, but dang, if it didn't just make me feel like, oh God, of course. I think it's so easy to go through like putting out fires and doing the work and not stopping to like reflect and hear about the experiences of people. Like, I just found it like to work with an outside organization who really took the time to like hear people's experiences and summarize it back to us was just like, it really kind of kept the fire going in a way that like constant responding to just constantly going through the motions can kind of really wear you down.
Thank you. I think we have a question now from Shelly Muller.
Yeah, hi, my name's Shelly Muller and I'm from New Mexico, and I used to run a pre-arrest diversion program based in harm reduction. And now I assist about 9 other municipalities around the state to plan and implement that same model. And we were able to acquire funding to assist people who are in this program with housing, or help a community that may be, it's really complicated, but to support a community to develop some sort of permanent supportive housing or something along those lines for participants in the program. And where I'm going with this is, the foundation of this program is harm reduction. And something I experienced in when I was working with the program in the city of Santa Fe is that if people could stabilize their housing situation, then they were able to work on other aspects of their life to address the chaos and even the way that they use drugs. And so I'm wondering if, in your programs, do you ever, so then I often question, yes, that worked for some people and we saw it, but didn't work for all people. So is that a reality? And I know you can't answer that question probably, but I'm wondering if in your programs, if you, either the temporary one or the ongoing one in Philadelphia, if you see people when they are able to stabilize themselves and have a secure place to go and be safe, if then they can start, or they want to, or they go to addressing the aspects in their life that may have contributed to where they were in unstable housing or homeless, and using drugs in a way that puts them at risk for arrest or other kinds of health outcomes. So I don't know if my question was succinct enough. So I'll start there and see if you can answer that. And if not, I can try and summarize my question better. Thank you.
I will say, if I understand, and I think I do, what your question is getting at, the answer I'll give is yes and no. Which is to say that I think for some people it really does. One thing, just, part of why our program exists, and particularly why our program is located where it is, which we used to be very much in the heart of Kensington. We were unfortunately, due to community and bureaucratic pressure, sort of forced to move just outside of that area. We, as an emergency shelter and as kind of like a first step, tend to really focus on bringing in and working with people who are really not in a place for many reasons that they are interested in or wanting to heavily reduce or change their substance use. I think in many cases that happens just because of the nature of what stability can bring. But we do tend to really focus on people who are I don't want to stop using. And we're also still right in the middle of a place where access to substances and the ability to use them pretty openly is very widespread. So it's something that people can keep doing. When we move people into programs that are willing to continue a conversation around what their substance use is and what that means to them and what are the compounding factors with that, then we often do see people successfully engaging in longer term MAT or, you know, trauma-informed mental health care, medical care, all of those things. So I think I would be lying if I didn't say that many of the folks that are in the shelter with us while they're there are continuing to use and not necessarily always addressing all of the compounding factors of that. Because we're able to start that conversation with them, if we can link them to longer term supports when they move on from our program, we can continue to see that success.
Yeah, I would second that. I'll just kind of add, one is that yes, and timelines are so much longer than anyone is willing to measure. And so I definitely, people might be willing to talk about some of their, whatever their destructive behaviors are. It just takes like years and years and years for some people. You know, some people are ready when you met them. And, you know, I guess the other thing is just like, there's so much research on the value of sleep, and just, you know, if someone is sleeping consistently, you know, in our qualitative study, they really talked about, you know, what you do to sleep on the streets, and it's like waking patterns, and you're never getting a consistent night's sleep. And we just know from research that like all the ways that that impacts your mental health and your physical health. And so I think it's basically impossible to not have your health improved if you're able to get a consistent night's sleep as like one very small part of housing as an intervention. And so you don't even need to follow your own people to say like sleep has benefits, and we're getting our, if you just, you're giving our people sleep and that impacts their health.
Thank you. Unless there's follow-up for that question, I've got a question. It's an anonymous question, so I'm asking for someone in the audience. My city has by default a hotel model that has established itself as a result of affordability and semi-permissive management. It's difficult to access those people. I believe the people in the hotel. However, because of police essentially staking out the parking lot, I'm in a state with prohibitive laws, and as such, am subject to search, seizure, and arrest for any distribution efforts. With such tight surveillance of these hotels, the city calls them sex and drug trafficking hotspots, overdose hotspots, etc. It's dangerous for my people to go there to serve. It's also difficult to identify secondary distribution that doesn't result in selling or manipulative trade of supplies. I'd love to hear your thoughts on navigating this sort of situation under surveillance. And then it says, for my folks who are housed, it's almost more difficult to get help as a result of these cops doing cop stuff. So any thoughts would be great.
I think, so first of all, kudos to you for doing that work. It's a totally different story to be doing harm reduction work in Baltimore than a lot of other places. So I don't know what I can tell you that you don't already probably know because you are doing the work. I think just, I'll say over time, the thing that it's helpful to remind myself about is persistence, and just continuing to look for those people who might be secondary exchangers, or continue to try and build relationships, continue to try and find your in. I mean, I don't know other cities, but in Baltimore, like everyone kind of knows everyone eventually. And if you're really looking for a way to get into a specific, like for us, it would be like a specific like little enclave or a certain alley or like a certain like spot where selling and using is really hot, you can eventually find someone. You just kind of have to keep trying at it over time and build relationships over time, which I'm sure you know. But I do think for myself, persistence is a good reminder, because there's so many things you can do that continuing to try over and over on something that's not paying off can be really hard.
Yeah, props for doing this work in that kind of environment. I sometimes forget how lucky we are to even have like the resources and the access that we do have. And what Natanya said really about being persistent and trying to identify secondary exchangers, longtime participants who, you've developed that relationship with. That's been where we've seen the most success.
Thank you for that. We have another question from April Provost.
Good afternoon. I'm April Provost. I work for Ideal Option and I am in Washington State. And my question is we have a big barrier with folks that are law enforcement involved or criminally involved. They're, I guess, fear of reaching out for any services because of the impact that might have. They feel like they might be turned in or that it's going to bring them into contact with law enforcement. And I'm wondering if you guys have witnessed or encountered those same barriers and how you mitigated some of that. Were you able to help them, advocate for them to like maybe get warrants squashed or to help them with their legal issues to become stabilized so that they can get into a longer term housing situation? Because I know that creates a barrier for leases and people that would be willing to take a chance on them.
Yeah, we actually, Prevention Point Philadelphia, once again, is a larger organization, was able to enter into a partnership with our public defender's office, which is run by Larry Krasner. Many people know, one of the more liberal district attorneys in the country, so fully recognize that is probably one of the privileges that is coming with this. But we actually have created we have a point person in the DA's office that will try to advocate. And then we also have that one, I will admit, is like sort of mitigated by like they are the district attorney. They ultimately do have to prosecute crimes that are put on their desks. So we also have a direct contact with the Defenders Association, and they will do things like they will try to get our big thing in Philly is detainers. We'll end up with folks who get held on a detainer for an old warrant. So they'll try to lift detainers. And they have done trainings and workshops with our team. This was actually, in my opinion, one of the more successful ones, where they've like taught our team how to write really succinct and strong advocacy letters for folks that are going to court on detainer hearings. So how to like write a harm reduction focused, but still like going to appeal to the court letter to advocate for our folks who might still be struggling, but nevertheless able to get them out of that detainer case. So I think if you have those connections to your local Defenders Association or someone in that realm, it took some persistence and really kind of actually getting someone from the Defenders out to our location to see the level of the need and really getting them there. But that has ended up being an incredibly fruitful partnership. And we also are partnered with we are co-operating a police assisted diversion model with the local law enforcement, as well as a few other organizations. So that's also been an area where we've seen some success.
And I'll just offer that it makes me feel a lot of gratitude for the people that are willing to do the work that's like the intersection of public safety and harm reduction. I really struggle with that. And I'm glad that some people I think there's been, I think there's a lot of things you could say about LEAD and a lot of collaborations between harm reduction and public safety, but it has presented opportunities to have more of a sympathetic ear from local folks. And so I guess if I were running a small organization, it would be really hard for me to do that work for advocating with my local DA. Well, I certainly don't do that, but other people do it. But I wonder if I could follow up with like some national groups that are really good at kind of making those connections. And I can see that like CDC is like pouring money into public safety and overdose prevention partnerships. And so I know that that's like a sort of more upstream solution, but there has been like a little bit of a softening from an overdose prevention perspective. And I think that can be an in that some national groups seem like they're willing to take on.
Okay, now we have a question from Audrey Lambert.
Hello, thank you both so much. This is really awesome and appreciate the work you do. I work for a surrender service program in Massachusetts, and you both had mentioned some challenges working with landlords or different hotels. And it sounds like a lot of the work you've been able to do is just sort of luck and finding the right people. But I'm wondering if either of you can share a little bit about how you were able to sort of build like positive relationships with property owners. Do you have any like specific strategies or approaches that you would recommend?
I can just start talking a little bit about, with the hotel staff, we now have landlord relationships, which I find really challenging. And I'm looking forward to like someone telling us how to make those easier. With the hotel staff, I would just say like we were we worked hard to be very reliable. So if they made a complaint, like we showed up and took care of it. We were kind of transparent about like what we can and cannot do. And we bought them lunch and flowers a lot because also there was a hotel staff working in the middle of a pandemic, but we did like Grubhub gift certificates. We like dropped off flowers. We would make little gift baskets. Like really, really, really work to maintain that relationship. But dang, landlords, I really struggle. Kate?
Yeah. I will say that I think one of the unfortunate barriers that we hit just in terms because of where like what our funding and what the expectation from our city contract is that often we might be the person who is finding the landlord for somebody, but we are not necessarily responsible on paper for maintaining that relationship once the person has moved into the unit. So I am in no way an expert on maintaining those relationships. I am going to once again shout out Andy and the teams at Pathways to Housing PA as people who are really well versed in that. And folks should definitely reach out to them to talk about what that looks like. What I can speak to is just that initial finding of landlords and some of the upfront conversations that we really do try to have with people about, and I think especially at this point in a lot of cities, I think these rapid rehousing and emergency housing voucher programs have been around long enough that like the moment you cold call a landlord and say, I'm like looking for units for a person with this voucher, like there's already a reputation that has preceded the conversation you are about to have. So we do a lot of like really trying to highlight the supports that our folks are going to be bringing with them. We try really hard to not move anyone into an apartment without assigning them to some kind of targeted case management or intensive case management, or like if they have a link to a case manager, like through our medical case management or our MAT program, really talking about how that case manager can continue to support them because they have the flexibility to follow the person, not the bed in the in our shelter. And then unfortunately, and I think like this is like, the ickier side of this in some ways, it's also having a conversation with our participants about what that initial engagement needs to look like. So we've done the type of thing where it's like, okay, your appointment is at 1. If you get well at 11, you'll be able to like feel good enough to get to the appointment, but you also won't be feeling so good that you can't like stand up straight. And it's really icky to have those conversations, but like when you're operating in this landscape, sometimes that's the reality that we're having to work in. And so like but if you want to put like a positive or a strengths-based spin on it, I would argue that's at least a more upfront and honest conversation than what a lot of folks, I think, in other spaces where it might just be like, you better not be high at this appointment. Like, we're going to really look at this from a planning of like, when do you need to do what you need to do? How long before? What's that going to look like? So it's a really uncomfortable and icky conversation that we have to have with people, but it feels important.
So now we have about 4 minutes left. So I want to leave maybe another minute or two if anyone has any last questions before we wrap up. Yeah, questions for Natanya and Katie?
I had one question. Hello, everyone. How you guys doing? Oscar from LA, Hopics. Did you guys experience any overdoses, or were you guys collecting any, conducting any needle exchange in the rooms or with the participants when they were staying with you guys? Or if so, how did you guys go about it? I mean, obviously Narcan overdose, I know that, but you know, since it was at a hotel, for example, with Natanya, or I'm not sure if the shelter that Kate was running, if it was allowed inside or outside. Just curious on those thoughts.
You know, we didn't have any any fatal overdoses in the room. And the other hotel programs in the city had a lot, and actually had quite a few deaths. We did a lot of overdose. I mean, you can't prevent every overdose death. I'm not gonna a lot of that was luck. I think some of the things that we did that really allowed us to decrease the chances that people would die is that you were able to bring in friends. You know, like you have a lot of these programs that say you can't bring in visitors, and like no one's going to reverse your overdose if you can't bring in visitors. And also, like, people are grown-ups and they can or cannot manage these relationships. And so I think, we did a lot of like one-on-one counseling, like, okay, let's think about how to reduce your risk. But a lot of it was just like, we let people bring their friends, and people had Narcan, and we had it like readily available, and we had those conversations up front. There was a lot of drugs and paraphernalia in the rooms. We would do wellness checks, and if someone hadn't answered their door in a few hours, we had like a master key to get in, and there was like a lot of drug paraphernalia. The hotel staff, obviously, like, we found a really awesome hotel staff, but also people do drugs in hotel rooms literally every day. So they just weren't fazed by it. They're like, oh, a crack pipe. Yes. I clean up crack pipes every day before or after the pandemic. So, I do think some of the rules or lack of rules we had was able to, let people continue to do the things they do to stay safe.
I'll jump in really quickly. So we unfortunately cannot do exchange at the shelter. The city is very prescribed in like where we can do these things, especially as prevention point. We're actually currently working with our syringe services team to develop like an IOU system to kind of reduce the amount of biohazard that is in the space, and also the amount of time we have like sharps containers in the bathrooms that people have learned to break into because they want those syringes to then exchange. So we're trying to figure out both an IOU program so that we can collect the biohazard like on site in a centralized place, but still get folks what they want on exchange days, and also trying to figure out some way to like get what is being appropriately put in our communal biohazard like redistributed to the participants in a way that feels equitable. So we're actually just starting to kind of figure out that logistics. We unfortunately do have people overdose in the site. It really ebbs and flows with the drug supply. Lately, unfortunately, like, we're seeing less overdoses, but we are like in the height of like the xylazine crisis. So instead of overdoses, we just have a lot of really gross open wounds. We have unfortunately lost 3 people on site. All of them were people who were found like in their sleeping area. And all of them were people who were incredibly medically fragile in addition to their substance use. And so we think it was just kind of a combination of all of those factors. And it's obviously like an incredibly tragic part of our program. But to Natanya's point, we've been doing full-time, we've been doing year-round shelter since 2017. And we've only ever lost 3 folks on site, and many of our other shelter providers in the city have unfortunately lost far many more because they're not able or willing to implement all of the examples that Natanya brought. Yeah.
Thank you, ladies. I appreciate that information.
Thank you so much. We're at time, folks, which is disappointing, but just really happy to have you both presenting, and folks that showed up, thank you for showing up. Thanks for coming in with your questions. We will have one more webinar as the last of this series next month, the first Wednesday of the month, and we'll definitely send that out on our listserv. But again, definitely please contact us if you have questions, or Katie's put her email here in the chat box. So let us know, keep us posted about what's going on with everyone. Thank you so much, everybody.